All right, team, listen up. We're talking constrictive pericarditis. This is a structural problem, a cage. The pericardium gets thick, fibrotic, calcified. It turns into concrete. And that concrete cage limits diastolic filling, but it does so in the late phase.
First sign to look for, Kussmaul sign. That's a JVP that actually rises on inspiration. On auscultation, you're listening for the pericardial knock. It's a high-pitched sound and you'll hear it in early diastole.
Now, what causes this? Globally, your number one suspect is tuberculosis. Here in the West, though, it's usually post-surgical or viral. For your workup, you are hunting for two things: a calcified ring on the chest X-ray and the classic square root sign on catheterization.
And the fix? There's only one. You have to strip the sac, know the knock, find the calcium, free the heart.
Let's go.
Before we proceed, we must address the mandatory international medical disclaimer. This content is provided for educational purposes, intended for international boards preparation only. It is not and should not be considered medical advice. Always consult official guidelines and a specialist physician for any and all clinical decisions.
Okay, Sarah, we've talked about the fire of acute pericarditis, but what happens next? What happens when that fire leaves behind a house made of stone?
So, tell me, why does the heart in constrictive pericarditis struggle so much during diastole? It all comes down to the filling limit, Dr. Collins. See, in the very early part of diastole, the heart fills just fine, really rapidly and normally. But then, bam, it slams into that rigid, non-compliant wall of the calcified pericardium. That sudden stop, that abrupt halt to blood flow, that's what generates the pericardial knock. It's high-pitched, you hear it right after S2, and it's quite literally the sound of the heart knocking on a concrete door it can't get.
Knocking on a concrete door. I like that, very vivid. Okay, let's move up to the neck veins. Now, as every medical student knows, the JVP should drop when we breathe in. So why on earth does it rise in these patients?
Right, and that's the Kussmaul sign. So normally when you inhale, the negative pressure in your chest sucks blood into the right side of the heart. But with constriction, the heart is trapped in that concrete shell. It cannot expand to accommodate that extra blood. So where does the blood go? It backs up. It backs up right into the jugular veins. And let me be clear, this is very different from tamponade, where the Kussmaul sign is usually absent.
That is a critical distinction. Tamponade gives you pulsus paradoxus. Constriction gives you the Kussmaul sign. And everyone watching, make sure you check the resources and guidelines we've linked below, especially the ESC document. It really emphasizes how key imaging is. So Sarah, speaking of imaging, what's the classic finding we're looking for on a simple chest X-ray?
A calcified ring around the heart. It's absolute diagnostic gold.
And if we take the patient to the cath lab, we see the square root sign. You might also hear it called the dip and plateau pattern. What you see is the pressure dropping really fast in early diastole. That's the dip. But then it just hits a wall, a flat plateau, because the heart physically can't fill any further.
Perfect. Now, you touched on this, but let's be specific. The causes, they really differ by geography. If you are practicing in a developing nation, what is the number one cause you absolutely must rule out? Tuberculosis. Always. No question. In the West, it's a different story. It's more commonly idiopathic, viral, or, a complication from a prior cardiac surgery or radiation therapy.
But regardless of the cause, the bottom line is the same. Meds don't work for stone. The one and only definitive treatment is a pericardiectomy. You're literally carving the heart out of its shell.
So that brings us to our question of the day. Have you ever seen one of these? A chest X-ray where the calcium was so thick, so dense, it looked like the heart was wearing a literal suit of armor. Let us know about your best radiology catches down in the comments.
All right, Sarah, let's lock it in. Lock the concrete cage.
Knock is the sound.
Kussmaul is the rise.
Calcium is the ring.
Square root is the sign.
TB is the source.
Surgery is the force.
Cage locked. The two big takeaways are the pericardial knock and the Kussmaul sign. And remember to review the links. Excellent work. So we've broken the concrete cage, but what happens when the sac isn't hard, but just leaky and systemic? Make sure you subscribe and join us for Module 4, where we'll tackle pericardial effusion and uremic pericarditis.